and I'm the communications lead at Orchid Project. Thank you for that, Amy. Orchid Project are an INGO with an office in Kenya and London, and we're working to end FGMC. So thank you so much, everyone, for taking your time out from your day to join our webinar. We really appreciate it. The role of medical and healthcare professionals in the UK is essential in helping to end FGMC as well as supporting survivors. Today, our event is tailored toward frontline workers interested in the safeguarding and support of FGM survivors in the UK. Thank you so much for submitting your questions. We'll try to cover these during the panel discussions and then also afterwards in our Q&A session. And before I dive into our introductions, I'd just like to cover a few little bits of housekeeping. So as you already would have heard, Amy is recording the webinar. So we'll make sure that we can share this to everyone afterwards, or for anyone who hasn't been able to join the session, along with some additional resources. If you could please keep yourself on mute and also turn off your cameras. And we invite you to put any questions or comments in the chat box, and then we'll address these in the Q&A session afterwards. The panel discussion will last for around 30 minutes. And then, as I mentioned, we'll go into the questions after that. And the session will not be any longer than 45 minutes. So as we know, all of you are extremely busy people, so we don't want to keep you any longer than we need to. So let's jump into a round of introductions. So we've got Dr. Rafiq joining us. She's a GP partner as well as a GP educator and is part of the Malaysian Doctors for Women and Children. So thank you so much for joining us. I'd also like to introduce Dr. Kinkaid, and she's a military doctor and the co-founder of the FGM Education Project. Thank you also for joining us. And then last but not least, we have Sean, who is joining us from Orchid Project. He's the head of research and capacity strengthening, and he pioneers interdisciplinary research on FGMC. So thank you so much for everyone for joining. And now I'd love to jump straight into the questions. So the first one is for you, Dr. Rafiq. Please, can you tell us what FGM is and what are some of the health complications as a result of this?
Hi, everybody. I've already been introduced. I'm Dr. Rafiq from Malaysian Doctors for Women and Children. I'm happy to be here on the panel and to answer some of these questions. As we know a little bit about me, I'm a Malaysian doctor based in the UK, and the MDWC is passionate about the academic and scientific discourse of non-medical cultural practices that affect women and children, and of other health inequalities experienced by minority groups in Malaysia. So jumping in quickly with the what is FGM and what are some of the health complications as a result of this procedure. So as we know, FGM/C or FGMC is all procedures where part or all of the external female genitalia are removed for non-medical reasons. Other terms can include female circumcision, cutting, and in Somalia, it can be called gudnin, and in Sudanese, it can be known as tahur. It is, unfortunately, FGMC is a very deeply rooted traditional practice that occurs in specific populations. It can be performed at any stage of a woman's life, from infancy right up to adulthood. It is most commonly performed before puberty, between the ages of approximately between 5 to 8. And what we all know and need to be always aware of is that FGMC violates human rights conventions that protect women and children from cruelty and violence. So if I talk about the types of FGM, Amy, if you don't mind sharing that diagram I had about the types of FGM, that would be great. Thank you so much. So I'm sure we're all aware as medical professionals, healthcare professionals, even as teachers or any professionals that work with children, what FGM or FGMC is. And briefly, I will go through the types. So type 1, as you know, is also known as clitoridectomy, where you have partial or total removal of the clitoral glands and or the clitoral hood or prepuce. And then that is further broken down with type 1A and 1B, which I won't go into today because of time constraints, but that's type 1, clitoridectomy. Type 2 is then the excision, where you get partial or total removal of the clitoral glands and the labia minora with or without removal of the labia majora. And then type 2 is then also broken down in type 2A, 2B, and 2C, and there are different variations to the type 2. But the important thing to remember about type 2, it's an excision of clitoris and more than that, labia minora and or majora. Type 3 then is infibulation, where you get a narrowing of the vaginal opening with the creation of a covering seal. So if you look at the diagram, all the amber bits or the dark sort of amber orange bits that are highlighted are the parts that are excised or cut. So if you look at type 3 infibulation, they cut the labia minora, the clitoris, and the majora, and then create a narrow seal by stitching the parts left together. And then type 3 again is broken down into 3A and 3B. And then type 4 includes any other harmful procedures, including piercing, incising, scraping, cauterizing, and pricking the female genitalia for non-medical reasons. I mean, this practice that we're trying to change in Malaysia a lot of the time involves pricking or nicking of the clitoris. And the requirement is to draw a single drop of blood, which it just satisfies a ritual. So a lot of the organizations or the Islamic Directorate in Malaysia want to try to distance the Malaysian practice from the FGM that we talk about generally here in the UK and other countries. Either way, it's still harming. It's still a medical practice that has no medical benefits. So yeah, we talk about the health complications, going in briefly. Severe pain. So I would divide it into short-term and more longer-term complications. Short-term complications would be severe pain, obviously. There are studies that have shown that infants feel the same pain intensity as adults. And this has been proven in functional MRI imaging, where the brain regions that correspond to pain light up in infants in a similar way to adult brains. So severe pain affects all ages, whether it's an infant or an 8-year-old or an adult. Hemorrhage or excessive bleeding, genital tissue swelling, fever led due to infections. And when I say infections, I mean things like tetanus and bloodborne viruses like hepatitis B or HIV. They can get immediate urinary complications, wound healing problems, injury to surrounding genital tissue and also surrounding pelvic tissue, pelvic organs, shock, and sadly death is also a known complication. Moving on to long-term complications, you know, we see a lot of this in general practice, not directly because of FGM, but we see a lot of things in women, problems involving urinary incontinence, recurrent UTIs, painful urination, and it's always worth having in the back of your mind, you know, what could potentially be the cause of this. Vaginal problems like vaginal discharge, vaginal itching, secondary to recurrent infections like bacterial vaginosis, menstrual problems, painful menstruation, difficulty in passing menstrual blood, especially in type 3s with the infibulation, scar tissue, keloid formation can be a problem later on, sexual problems. So you can get pain during intercourse or decreased satisfaction in sexual intercourse. Infertility can also be a problem. There is an increased risk of infertility. And if, however, you do manage to become pregnant as a survivor of FGM, you can have an increased risk of hemorrhage and complications during childbirth. Newborn death is sadly a known complication, and a need for later surgery. So type 3 may lead to de-infibulation, where the procedure involves opening up or widening the vaginal canal. And then, of course, complications that is difficult to measure and quantify, but psychological problems like anxiety, depression, post-traumatic stress disorder, low self-esteem can all stem from FGM. Yeah, and a few things with pregnancy and women who have had FGM. If a midwife picks up in the booking appointment that there has been FGM or some damage that has been done to the vulva or the external genitalia, then a referral to an obstetrician is important to have a further assessment, to think about, to see, is the vagina too narrow? Will the woman require a surgical procedure, like I mentioned earlier, the de-infibulation, and to signpost them to other specialist clinics if needed. I hope that's in answer to the questions about the complications and what FGM is.
Thank you so much. That was really a lot to cover, and I think it's so important to go through all the different types of long-term and short-term complications. Sorry, Sean, did you have something to follow up on? No. Okay, great. So, well, we'll go to you next anyway, Sean. From a data perspective, what do we know about the prevalence of FGM in the UK?
Thanks, Natalie. Hey, everyone. Nice to be here with you today. So maybe just a minute on how we get to the data. In diaspora contexts, the methodology that's most often used to establish the extent of FGM prevalence within the community is the extrapolation method, which at its sort of very root relies on three variables. It's the population, so we get that from the census in the UK. The prevalence in the country back home, in the country of origin, and we multiply that together. So 1,000 Somali women here, 99% back home, so 990 potentially here. On the other hand, 1,000 Nigerians, 19% back home, so 190 Nigerians here. You know, so we do that maths, and then there's a third variable which looks at the extent to which migration and acculturation lead to a decrease in the practice over time. And so the children that are born there versus who grew up here, and then the kids who are born here, that there's this decreasing level of risk. So the latest available study like that in the UK was done by the City University of London, looking at England and Wales based on the 2011 census. There is a study currently going on at the University of Birmingham with Home Office that will update that to the 2021 census. But based on the 2011 census, the number of women and girls potentially impacted by FGM in the UK is at 137,000. About half of those live in London, and within London's the boroughs of Southwark in the southeast and the borough of Brent in the west are clearly by far the sort of outstanding kind of areas where FGM is most prevalent. Then in the northwest, Manchester, Sheffield, about 25%. The Midlands, Birmingham, Leicester, Coventry, Northampton, about 10%. And then, you know, Bristol, Reading, Oxford, Cardiff, you know, there's smatterings across the rest of the country. But really those three areas of London, the Northwest and the Midlands make up 85% of the impacted population in the UK. About half of those women and girls come from or have families that come from communities overseas that practice type 3. So that would be Somalia, Sudan as the two primary ones, and there are others. But, you know, obviously they would have somewhat more significant healthcare needs than maybe, you know, somebody that comes from a type 1 practicing community. And so the biggest two groups that come out in the census, about a third of the impacted population are Somali in the UK, and about a quarter are Nigerian. And then, you know, we know that the practice happens in about 90 plus countries around the world. 30 or so of those are diaspora countries. And so we know that it's 60 plus countries. So, you know, flagging up two, there's another 48 or so, 58 countries that are probably in the mix. And, you know, I was on the tube yesterday just looking at who was on the tube and thinking, you know, we really do have the United Nations in London. So, you know, it's not just those two, is I guess what I'm saying, all the other communities. And so the real thing is to look at, you know, if you go onto our website and look at the prevalence rate in the country of origin. So if you've got a Ghanaian, you know, woman coming to see you, what is the prevalence in Ghana? And then start to kind of say, okay, is it more or less likely that this is going to be a person with FGM? You know, that would be at the very first stab at just trying to have a guess at it. Back to you.
Thank you so much, Sean, for breaking down the data and explaining how you got there. And I think it's really important to understand the data in terms of what that means for the healthcare needs that people might be having. So moving on to you, Dr. Kinkaid, if that's okay. Please, can you run us through what do doctors need to know about FGM and where can they access this information?
Thank you for that. So my name is Dr. Kinkaid and I'm from the FGM Education Project, which is basically, I'll give you a quick summary of what we do. So we're all about educating frontline professionals on their mandatory reporting duty towards FGM, with the ultimate goal of helping to end FGM. And we believe that this is through a multi-sectoral approach and that frontline professionals, like everyone in this Teams meeting, are key to doing that. So yes, so what do we as doctors need to know, or we as healthcare professionals need to know about FGM? So importantly, we need to talk about the two kind of laws in the UK on FGM. So the FGM Act of 2003, firstly, is an act, the act that essentially says that FGM is illegal in the UK. It also says that FGM is illegal to take a girl out of the UK to have FGM performed. So that is the act that makes FGM illegal. The second law that we need to be aware of is the Serious Crime Act of 2015, and this is really important for us as healthcare professionals. So that act says that it's mandatory that we report all known cases of FGM to the kind of right people, and we'll talk a little bit about that. So we must report FGM if we see it, and it also made it illegal to fail to protect a girl from FGM. So how that applies to us, if you see a woman in clinic who has had FGM performed and she has daughters, it's your duty to report that and ensure that those children are safeguarded, and that's written in law, so that's really clear. The next thing I'd say, so are kind of legal duties, but then also kind of being able to understand what FGM is. And what we have found with our project is that a lot of people don't understand what FGM is, and we've had Diyanah's really kind of made that clear earlier with the different types and things like that. But ensuring that we know the kind of signs of FGM and what we'd look for in clinical practice. How we can kind of talk about that in clinic. I know there's been a few questions on that, and I'll cover that now because I think it's really important. Discussing FGM sensitively, and as you've heard from Sean, there's different places that people come from the FGMs are formed, about 50 to 58 different countries that practice FGM. They'll all have completely different ways of talking about FGM. And you may have heard earlier that Diyanah kind of talked about in Sudan, it's called tahor. So calling it FGM to a patient they may not understand what you're talking about. So you may have to kind of do a quick Google of the word that's used in that region. Also, a lot of women may find FGM, and FGM survivors themselves may find the term mutilation quite offensive. So you may have seen in other places it's called FGC, so female genital circumcision or cutting. So it may be that you kind of talk about it around female genital cutting rather than you going straight in with FGM, because it can be it's quite an aggressive term. So you may want to kind of think about it, kind of approach it sensitively. Where can you access information on knowing about FGM? So there's lots of resources. So our project runs a free online course on FGM on the Future Learn platform. So if you look us up on social media, it will be there, and we can send it out as well. There's lots of amazing charities that do amazing work. There's obviously Orchid Project. There's Avengers, Oxford Against Cutting for kind of local stuff. But also the NHS website has great information on FGM. And yeah, I hope that's kind of covered all the bits about FGM and the law around that. I'm happy to take any questions on that further later on.
Thank you so much, Victoria, for running through the main two parts of legislation there and what that means for safeguarding. But also, I think there were quite a few members of the audience who were really looking to hear about how to sensitively broach the subject of FGMC. So thank you so much for that. Moving on to you again, Dr. Rafiq. So can you please run us through a bit about how mandatory reporting works in practice and what are the challenges that are associated with it?
Thank you very much for that question. As a GP, day-to-day practice, day-to-day cases that we see in general practice, there are very, very few and far in between of what we see. That I, in my own personal experience, have never come across a patient with or that I have personally picked up on my examination or assessment or from my consultation to have been a victim of FGM or have undergone any sort of FGC. So I mean, I'm speaking from the perspective of, you know, what you would do or what is advisable as a general practitioner or any healthcare professional or professional, and that can include teachers or anybody who works with children. So I think it's important to use, like Dr. Kinkaid had appropriately pointed out, is that the communication, using the appropriate communication skills, giving the young girl, the child or the teenager that platform and space to have the opportunity to bring it up herself, because they may refer to it, you know, with different terminology. And I suppose one of the difficulties is trying to, once you've identified or you think you may have identified somebody who is at risk, you know, you need to be sure what then determines your next steps. Is this a mandatory reporting case? Is this a safeguarding case, or is this a social services referral? I find, or I have come across previously when trying to make this assessment, or when we've talked about it in the past. I don't know, Dr. Kinkaid, if you mentioned, but there is the FGM assessment tool. Just going through the questions does help. So if you look up National FGM Center, there is an FGM assessment tool which helps professionals go through the questions. It takes about 10-15 minutes to complete, to then help you make your decision to say, is this really something I need to go ahead and do the mandatory reporting. I mean, the best practice is to report the case or the girl that you're suspecting by the close of the next working day. But there are cases where you think, based on your professional judgment and from your consultation with the girl, her family, if you think that it could put the child at immediate safeguarding risk, and you think this needs a further consultation with my other colleagues or other agencies, like your safeguarding team or your safeguarding lead at the practice, then you can delay reporting it maybe by another day until you can be sure you're not going to put the child at imminent danger. Yeah, I think from a general practice point of view, we also see a lot of pregnant patients, pregnant ladies. So this is also a good time to kind of have those conversations, maybe not directly, but present that platform and space for them to bring it up if the opportunity arises. Yeah, so as a GP, I am the safeguarding lead at my practice. I have had doctors approach me, and if you are a GP and you're not the safeguarding lead, then go to your safeguarding lead. If they're not present on the day, they're not in on the day, then pick up the phone and ring your safeguarding team. For us at Bedford Central Beds Council, we have a number that I call all the time just to bounce off ideas, to talk about the case and what is the appropriate next steps. And then also discuss with your wider team, the other doctors, the nurses, and pick up the phone and ring the midwife to, say call the midwife, I'm thinking about the show, call the midwife and have that conversation to see what is the appropriate next steps.
Thank you so much for that and for directing us to the assessment tool as a practical way of approaching those conversations. Just to check, does anyone else have anything to say on that before I move to the next question? No. Okay, all good. So Sean, back to you with the data. So what are the latest figures around mandatory reporting and what do they tell us?
Thanks, Natalie. Yeah, so as Dr. Rafiq mentioned, ultimately this triggers, if this does trigger a mandatory reporting, then, that ends up in what we call the FGM enhanced data set. And if you Google that, if you Google FGM enhanced data set on the Gov UK site, the latest report, so that legislation came into effect in April 2015, and the latest report is up to September 2023. In that 8-year period, there's been 35,415 reported cases of FGM in the UK. So that's not incidents. There were more. There were more cases reported, but many of those were duplicate cases, and so 35,000 actual individuals. That's about a quarter of the 137,000 that one estimates from the 2011 study. So if we just use that maths, I think significantly 95% of that 35,000 were cut before they came to the country. So most of them in Africa, some of them in Asia. But that does leave about 5% that were cut in the UK. So that's 1,700 cases of something happening in the UK in that 8-year, that were reported in that were recorded in that 8-year period. There's a couple of other things about that, at that headline. The first thing is those didn't occur in that 8-year period. Almost all of them occurred historically and were then documented for the first time in that 8-year period. But looking at the enhanced data set, over 90% of those 1,700 reports were of adult piercings, and while that is strictly a type 4 FGM, it really is almost certainly more likely to be a cosmetic surgery, a cosmetic piercing that someone had as an adult. So, we're then talking about a much smaller number of girls who were probably cut in the UK. Maybe 150 or so, of which 50 of them we know in the data set. We know the age at which they were cut, the type of cutting they had, the geography where they were cut. I think what's significant about that number is that, let's take the 50, multiply that by 4, because we only have about a quarter of the number. We're talking about 200 cases. So it really is. There is a child protection requirement, but there is much, much more a health service requirement for women living with FGM. And I think how we get the balance of that right is always challenging from a safeguarding point of view, because clearly there are some girls who are at risk, but not all girls who are born to a Somali family are at risk. And so how we kind of manage that, or not all girls born to a Nigerian family at risk. The data seems to suggest that there's about a 75% drop-off in risk profile for girls who were born here to families from there. So, that in itself, gives you, again, if you go onto the website and say, well, Somalia's 99, so maybe if I've got a girl in front of me, there's a 25% chance, but still that's a high number. I think the thing I really want to sort of highlight is that there's 100,000 plus women in this country who need health services related to FGM, and there's some kids that need protecting.
Thank you so much for that, Sean. And yeah, I think those numbers really just show how important it is to have sessions like these where we can help to discuss FGMC, the needs of patients, and also reporting duties. So with that, we'll just move on to our final question before we go to the Q&A. So Dr. Kinkaid, alongside mandatory reporting, what other support have you experienced survivors of FGM needing?
Thank you. I think this is a really important question, because I think when I talk to healthcare professionals about mandatory or about FGM, they often talk about the mandatory reporting, which is really important. But we have to remember there's a patient at the centre of all this, and putting them there is really important. So making sure that anything that we do is kind of survivor centric. So Dr. Rafiq at the start covered all the complications of FGM really well. And so I'm just going to kind of talk about the kind of specialist referral that they may need. So of course, if you get a disclosure or you identify FGM as part of your consultation, first off, I'd say is making sure that communication is is there. So counselling women, talking to them about FGM, broaching the subject sensitively, and believing them. There's lots of different types of FGM, and people often jump to thinking about type 3, but if they've had, for example, we talked about a clitoral pricking, if they've talked about having that as a child, it's not, you kind of want to take that with the same kind of belief as type 3, which is very obvious. So I think believing women's really important, especially in women's healthcare at the minute. And then treating any acute symptoms that they may have. So any of the kind of problems that we've talked about, and any of the short-term complications, so fever and things like that, you may need to start antibiotics. Then you want to think about onward referral. So Potentially they may need psychological support, so they may need secondary care for PTSD therapy. If they're pregnant, as we've talked about, they'll need obstetric referral, and that'll go via the midwife. And you may want to talk to them about the fact that their delivery might be slightly different because of the FGM that they have. What's really important is psychosexual medicine, and we're finding that there are a lot of women living in the UK who are suffering from the long-term impacts of FGM, and a lot of that is psychosexual. And I think in women's health in general, we don't talk about psychosexual medicine enough. And this has, you know, we've talked about FGM. We remove the clitoris. That's the whole function of the clitoris is sexual pleasure, and that's really important for women. So making sure that we do that psychosexual referral and getting in that support that they need. And then if you have a local FGM clinic, which there are in places like Bristol and London, the Midlands, and you can refer them there, and they'll get the kind of specialist counselling and things as well. And yeah, so again, surgeons might be another option if they want a kind of defibrillation, or there's even stuff going on in France where they're refashioning the clitoris for FGM survivors. So that's kind of things that we could be thinking about. But I think the most important thing alongside the mandatory reporting duty is just that kind of listening to women and sensitively talking to them. You might be the first person they've ever talked to us about their FGM. So kind of just being a person that's listening and believing them. Yeah, so that's all I have.
Thank you so much for running through all the different types of support, and I think it is so important to reinforce delicately approaching conversations and being supportive. So we're just going to move on to some questions that we've had through for Q&A. So Sean, I don't know if you're happy to speak to this one, but we've been asked, what are the government's inputs to end FGM in the UK?
Yeah, and as I answer that, Natalie, that Lisa popped something in the chat around, do we report all FGM in adults? And yes, you know, from a mandatory reporting point of view, you report every adult that you come across that has had FGM, and then it gets sort of filtered through the data set, and then all the duplicates get taken out. And so it's not, the mandatory reporting is not just a child protection element, it's also a sort of caseload element. So, you know, what is the UK government doing, you know, sort of across all this departments? So obviously NHS, you know, we've already spoken about that, the mandatory reporting, the specialist centres and so on. Home Office has a specific unit focused on honour-based crime, which includes FGM and forced marriage and, you know, and a bunch of other pieces. The Met Police have a similar crime unit, as do several of the other police forces around the country. And those leads of those different police forces, the FGM or the honour-based crime leads get together quite regularly, both across the forces and with community liaisons in affected communities. Border Force has a program called Limelight, which focuses on trying to prevent girls being taken overseas for holiday cutting. It's kind of operates quite similarly to the anti-trafficking stuff. There's in some of the bathrooms in the girls' bathrooms, there's sort of notices behind the doors around if you're being trafficked, and there's also sometimes notices around FGM depending on which airport is typically being used. That Limelight program also shares, and that Border Force program shares intelligence across Europol and across the US, and that in terms of trying to pick up what's happening. Then there's the National FGM Centre, which isn't government per se, but it is kind of the government-y kind of, it's a civil society piece of the puzzle that is sort of the main thing. And if you're looking for, what to do, Googling National FGM Centre is not a bad place to start. There's a lot of good resource links and that off of that'll get you to places. Then in education, there is a piece of curriculum within the PHSE curriculum in high school in Key Stage 3, specifically talking about FGM. And the mandatory reporting is not only for medics, it's also for school teachers and a couple of other professions as well. And then FCDO, the Foreign Commonwealth Development Office, they focus on anti-FGM programming, particularly in the Horn of Africa. So they fund work in Sudan, in Somalia, in Ethiopia, which are, all have really high prevalence, and a lot of those communities live in the UK. And so there's sort of a bit of logic in terms of where they're funding the anti-FGM work.
Thank you so much, Sean. That was very comprehensive. We have another question here, and I think we've probably partially answered it, but maybe Dr. Kinkaid, if you could just quickly go over this. So we've got a question: if a woman has FGM, would you class all female descendants as at risk and code them appropriately? Does this include daughters and granddaughters?
Yeah, happy to answer that. So, yeah, from a safeguarding perspective, the answer is yes. Having a mother who has had FGM makes you at higher risk of having FGM yourself. So, I would do a safeguarding referral for that, because it's our mandatory reporting duty to look for women at risk of FGM as well. So personally, if I was in GP, I would talk to the woman about FGM, and see you can talk about intentions for cutting children, her children, but you would probably want to do a safeguarding referral, just to make sure that those children are protected. So yeah.
Yeah, I agree, Dr. Kinkaid. That's probably the right thing to do. I mean, if the only risk factor is that the girl's mother or grandmother has undergone FGM, you don't necessarily need to refer that child to social services as such, but the step below that is to make the local safeguarding team aware, and then it might be worth setting up a recall or sort of an annual or 6-monthly just check, a conversation or a catch up with the patient, the family, the child. What if you are made aware that there are new travel plans, they're planning to go back to their home country for a special occasion, or they have extended family coming to visit them. Yeah, it just brings to surface and keeps it in the back of the minds of all the agencies involved.
I think the other piece, maybe just to add to the mix there, is the age of risk of cutting, which is very, very different in different communities. So, the Indonesian, Malaysian, Yemeni, Nigerian community are all really at risk within the first year or so. And so a 12-year-old going back to Malaysia is probably not at risk of FGM. Whereas a 12-year-old going back to Somalia probably is at risk of, or possibly is at risk of FGM. And so you kind of need to think of when is the girl most likely to be cut, and there's sort of really 3 groups. There's those that cut within that sort of first year or so. There's the group that cut just before puberty, and then there's the group that cut kind of just around the edges of kind of just after puberty. And again, you can find that on our website, the link to that, and to then just connect those dots. If you've got a Nigerian going back to visit their family as a teenager, you really aren't raising the flag. Whereas if they're going back as a baby, you might want to raise the flag. And I think that's just, sorry, I cut you off, Victoria.
No, thank you. That was really helpful. I think Dr. Rafiq kind of covered it, but it's a multi-agency approach. So I think never feel like you're on your own. And if you are worried, do make the referral. And then the multi-agency, you know, there's multiple people there that are gonna kind of look into it further. It's not kind of all on you as a GP or someone in healthcare. It's a good first step of making that referral, and then it's not that anything drastic is going to happen from that referral. It's that they're going to make a risk assessment. So don't feel like it's all kind of on you is what I kind of wanted to say.
Thank you everyone for joining for that answer. And yeah, Victoria, I think it's really important to emphasize that there is support there also, because reporting is quite a big responsibility. So it's nice to know that there's support there for everyone else too. I'm very conscious that we've kind of gone slightly over the time we've set. I don't know if anyone has any other pressing questions. If you want to quickly drop them in the chat if you do. Otherwise, we'll be following up with some resources after this webinar, and we'll also be sending the recording for anyone who wants to kind of go back. But thank you so much everyone for attending. Thank you so much for our panel as well, for taking their time out of their days. And we hope you found this useful and yes, and informative. So thank you so much for your time, everyone. Bye, everyone. Thank you.
Thank you. Bye.
Thanks. Bye.
Thank you.